The main portion of today's CE covers the concept of crashing patient management. I'm going to give you a quick little introduction before the rest of the team takes over. Here's what we're going to cover. I'm going to give you a quick intro, and then the rest of the team is going to cover our new crashing patient protocols, one medical, one trauma, and then a little bit about our new traumatic cardiac arrest protocol as well. Those of you who have been around for a few years will have recognized that over the past 3 or 4 years, we've been talking about this concept of sudden ambulance death syndrome, or what we call SADS. We've been reviewing cardiac arrests for a number of years now. And back in 2015, 2016, we started noticing a trend of cases that weren't your standard cardiac arrest, where a patient would go into cardiac arrest, EMS and fire would be activated, we would show up on scene and work it like an arrest. Instead, these were cases where we would show up and the patient would be short of breath or have chest pain or be otherwise unwell, and they would decompensate on their way from the house to the ambulance. We started looking into these and recognized that these patients were critically ill at the moment that we found them, and we could have done a better job at stabilizing them prior to moving them to the ambulance. So we developed training, we developed a protocol, and we've been talking for a while now about this concept of stabilizing on scene prior to moving them to the truck. In reality, we've had a bit of a pendulum swing. We do still have cases where patients are critically unwell and are still moved to the ambulance, decompensate, and die. But we also have cases now where we work towards this nebulous concept of stability, where we stay on scene, potentially for too long, both for medical and trauma patients, without a very clear goal in mind. At the same time that we were identifying cases like this, our colleagues in Pittsburgh were noticing the same thing. They had a rash of EMS-witnessed cardiac arrest, and they started looking into the reasons as well. What they recognized was very similar. They had patients that were critically unwell and decompensated and died on the way to the ambulance. They put together this concept of a crashing patient protocol, a series of actions that needed to be accomplished before a patient could be moved to the truck safely. It was so successful in their system that it was actually incorporated into Pennsylvania's state EMS protocols so that every agency in the state of Pennsylvania had something similar. What we've done is built upon their foundational work, added in our local information, and put together our version of crashing patient protocols, one for medical and one for trauma. This is what we're going to cover here in this session today. There's one fundamental difference about our protocol, not only compared to theirs, but also from what we've had before, and that's the concept of goals. There are very clear goals delineated in the protocols, something that we can all work towards. And it brings about this concept of goal-directed therapy. Goal-directed therapy is a protocoled approach with a bundle of actions aimed at specific resuscitative goals to help treat the patient effectively. This is not a new concept in medicine. It came from the sepsis days with the idea of early goal-directed therapy. Back in the 90s, we had a high sepsis mortality rate as a healthcare community, upwards of 65%. So a group got together and put together this process of goal-directed therapy, where fluid resuscitation always came first, and until adequate fluid resuscitation was achieved, you would not move on to vasopressors and then to inotropes. And a series of steps and bundles of cares were developed to help treat sepsis patients effectively with good effect. What we're doing is bringing that into the EMS world, specifically about these critically ill patients. And there's a few reasons that we're doing so. One, we want to work together to establish the priorities of what meaningful interventions need to be done where you find the patient. This falls in line with the common concept of ABCs, but is not being uniformly approached in this system. For example, if a patient on initial assessment is hypoxic with a SAT of 85%, that is not the time to focus on IV starts as opposed to bag valve mask ventilation. This is the first goal that we're trying to achieve, is to make sure that as a system we understand what our priorities are when it comes to critically unwell patients. The second one is to define these established targets. What are we working towards as a team to make sure that we can move this patient safely to the ambulance? Rather than give a nebulous concept of deciding subjectively whether a patient is stable enough to move them or not. This will give you clear goals to keep in mind as you treat these patients, as well as some exit strategies for why those goals may not be accomplishable. And the last one is to promote care as a system. This is something that we have struggled with for years, to get everyone who shows up to the scene to be operating off the same page. We have a number of great examples of fire and EMS working together towards great patient care. But we also have some struggles. and we need to make sure that as a team, we're working together to get the patient to achieve the goals that we need to move them to the hospital safely. The other thing you'll note about these protocols is we don't call out all of the medicine from all the other protocols on the pages. In reality, patients don't fall into one protocol and require the amalgam of information within the protocol books to be applied in each individual case. What we do is call out the important information and reference you to the other protocols so that you're making sure to treat the patient as a whole. The goal of this protocol is not to overwhelm you with the sheer amount of information that's in all the medicine that this patient may need. It's to help you apply the medicine that you already know to the patient that's critically unwell in front of you. The important thing to also note about these protocols is, unlike the rest of our protocols, these are linear. They start at the top and work through a series of arrows to reach the desired objectives. The other thing you'll note is, even though these protocols are designed to be used for critically unwell patients, in theory, you can use them for pretty much every patient you encounter. Most patients will meet the goals immediately and don't need anything from this page. But some patients may require a little bit of effort or a little bit of work. The important thing to understand is that the basics always come first. Every page starts with the pink box at the top. And for a lot of patients, that's all they're going to need. A little bit of oxygen may go a long way to getting this patient to meet the goals that they need. Remember, ALS is built upon a solid foundation of BLS, and until you achieve the goals of the basic care in most of these protocols, you shouldn't move forward to ALS care. So what are the goals that I've been referencing? They're different for medical and trauma. For medical, you have a respiratory goal. Either the saturations are going to be normal, or you'll have reached an exit strategy, such as a supraglottic airway with proven ventilation, but still the patient remaining hypoxic, or you'll have moved forward through your can't oxygenate, can't ventilate situation to a surgical airway, at which point you've reached the end of that process. Your circulatory goal, you'll have achieved a normal blood pressure, or you'll have finished your fluid bolus and started vasopressors. But this is an important concept. You don't need to stick around on scene to try and titrate your vasopressors to a level of normotension. Once you've started them, you'll be able to move on. All the details of this will be explained in the next lecture. For trauma, the goals are different. Obviously, catastrophic hemorrhage comes first. Once you've controlled catastrophic hemorrhage, then you can move on. But sometimes you'll reach the end of your protocol and the patient will still be bleeding. That's understandable. If you've got a wound packed and 2 tourniquets on and still oozing, that's the most you're going to be able to do, and it's okay to move forward. But if you've got a spurting artery and it just has a gauze pack on, that's not okay. You need to move forward and control that catastrophic hemorrhage before you address anything else. The respiratory goal is the same, but the circulatory goal is very different. In trauma, most of the circulatory goals won't be met until you reach an operating room or a trauma center. And we understand that. That's why it elaborates the necessity of transport of critically unwell trauma patients before meeting a circulatory goal. What's important about all of these goals is we're trying to find that balance and find that middle road of performing enough patient care and delivering enough medicine to make sure that they'll make it alive to the hospital or to their definitive treatment. But we don't want to do so much and spend so much time and effort that we actually deter from their patient care. So what's not included in these goals and what's not included in the protocols? Something you've heard us say time and again. Time is not delineated in these protocols. A hard set number of minutes is not the way to approach our patients. But importantly, you have to think of time as a currency. You only have so much time and so much currency that you can spend on any given patient. And each provider should be able to recognize what judicious use of time is. So for example, if you have that patient who's hypoxic, attempting 3, 4, 5 IV attempts is not a smart or effective use of your time and resources. Having said that, when you have a number of providers on scene able to dedicate their time and resources wisely, you can minimize the overall amount of time it takes to meet the goals and meet the objectives of safe transport of these patients. Set realistic time targets for your team. You know how long it takes to pressure bag in a liter of fluid. You know how long it takes to set up a kit dump or to get a pump ready or to set up for bag valve mask ventilation. Communicate as a team and make sure that you're discussing with each other what you think it will take to reach that goal, how long you think it will be until you get there. This will help our communication as a system. This will allow us to provide maximum simultaneous effort. If everyone is spending their time and currency wisely towards the same goals and towards the same objectives of good patient care, then we will overall improve our time on scene and our overall outcome of the patient. What we are trying to avoid is someone with a grenade trying to deter from the overall patient care by rushing the scene and pushing for transport of an unstable patient to the ambulance, or alternatively, staying on scene too long and trying to reach a level of stability that is not possible in the pre-hospital setting. Again, we're aiming for that middle road of the pendulum. One thing we've been noticing recently is failure to communicate on scene. Over the past several months, we've recognized a number of cases where communication was the answer to issues occurring on scene. We need to work better as a system to communicate our plans, to communicate our thought processes, and really work together for our patients. It's not okay to not elaborate what you're thinking and what you're planning on doing for these patients and pointing towards the goals that you're trying to meet. One of the big goals of this program and of these protocols is to get everyone on the same page so that everyone understands what stability means, what goals we're trying to achieve, and what a true safe transport of a patient really looks like. I encourage you, talk to each other. It doesn't matter what shirt you wear. It doesn't matter what patch you have. Everyone is focused on treating the patient effectively. Try not to make assumptions about each other, about everyone's intentions or their goals on this patient. Everyone in this system is working their best to help treat the patients effectively. We need to work together as a system to make sure that we can provide the best outcomes for our patients. Another important thing to notice as we go through these sessions today is the stark differences and the similarities between medical and trauma crashing patient protocols. We've had in the past issues where concepts from a medical crashing patient that we've taught before are applied to a trauma patient, and this can lead to bad outcomes. So notice where the similarities exist, like oxygenation and ventilation goals, but differences as well, such as the use of pressors or not, or when to start moving a medical patient versus a trauma patient. So notice the similarities, like the oxygenation and ventilation goals, or the differences, like the circulatory goals. Keep in mind, as you go through these protocols today, that there are big differences between medical and trauma patients, and we have to use the right frame of mind as we approach them in real life. One of the last things I wanted to mention was the concept of medical patients who have time-sensitive disease. We all recognize that a STEMI patient or a stroke patient has definitive care available to them at the hospital that we can't perform in the field. Having said that, there's no use taking a patient who's suffering a hypoxic arrest to the cath lab. We have to make sure we do enough care on scene to stabilize these patients to be able to transport them effectively while not spending so long on scene as to degrade their overall outcome. This concept of goal-directed therapy is something you're going to start seeing more and more, not just in STEMI, stroke, and other critical medical care, but things like your post-resuscitation period for patients who have obtained ROSC. Historically, we had had an arbitrary time frame, 10 or 20 minutes, on which you had to stay on scene to prove stability, when in reality, there are a series of goals that can be measured, such as a 12-lead EKG, adequate airway management, vasopressor initiation as appropriate. These are things that can be met before being able to demonstrate that that patient can be moved safely. Again, these are protocols and concepts that we will continue to incorporate in the protocols and will train off-cycle so as not to rush them. Again, as you go through these protocols, it may seem basic or it may seem straightforward like you've learned it before. I promise you, we would not be rolling out a program like this if this system didn't need it. We need to be working as a system towards defined goals with a uniform approach of how to take care of these critically unwell patients to make sure that we're able to safely and effectively get them to the hospital. We need to focus on what really matters, our patients, and use our toolbox wisely and effectively to get them the best care possible. Again, I appreciate your time and attention and your focus during this session, and I look forward to talking with you all as we start applying this protocol in real life. In reality, none of the medicine is new here. These are all concepts that you understand. It's how we apply them. It's how we use them in our day-to-day practice that may need to be adjusted. I look forward to the conversation and enjoy the rest of the training. Thank you.